morning, sir. Yes, sir.
Okay. I think we have finished mitral stenosis and mitral regurgitation in last class. Today we will do aortic regurgitation, aortic stenosis, and a little of tricuspid and pulmonary valves. Um, First, going through the aortic regurgitation, if you look at it, then it is more prominent and predominant in males if it is pure or predominant atrial regurgitation. But if aortic regurgitation is associated with mitral valve disease, such as because of rheumatic heart disease, then it's more common in the females. And two-thirds of aortic regurgitation is due to rheumatic heart disease. Basically, if you look at the etiology, then it's a rheumatic heart disease or infective myocarditis or any congenital abnormalities or collapse of the aortic valves. But there are few diseases of aortic root which can cause aortic regurgitation, such as cystic medial necrosis, syphilis, ankylosing spondylitis, even hypertension can cause aortic regurgitation. So, but mostly it's because of rheumatic heart disease. If you look at the pathophysiology, when there is a regurgitation of the blood from the aorta into the left ventricle, then there will be increase in diastolic volume. And as there will be increase in diastolic volume, then to accommodate this volume of to accommodate the volume of this end-diastolic volume, ventricles then gradually increase in the size because of the volume overload, and it will become hypertrophied, and there will be left ventricular hypertrophy. And because of the increase in LV chamber volume, which leads to the increase in the systolic wall stress and causes concentric kind of hypertrophy as well. But as the left ventricle function deteriorates, this end-diastolic volume will rise, and the stroke volume or ejection fraction will gradually decrease, and patient may develop mild ischemia also because of aortic regurgitation. So because of the volume overload, in this case, because of the volume overload, you will have a left ventricular hypertrophy. So when you examine a patient of aortic regurgitation, you'll find that apex weight is shifted downwards and upwards because of the LV hypertrophy. And because of the volume overload, you will have hyperdynamic apex weight. Now, if you look at the clinical features, the patient may be asymptomatic, but generally they start with palpitation. Then only they will have dyspnea, exertion, orthopnea, or PND. Then there may be sweating, chest failure. Later, there will be features of ventricular failure because of the involvement of pulmonary increase in the pulmonary hypertension and causing dilatation of right heart, and thus right ventricular failure. There may be other symptoms of other associated diseases like syphilis or maybe connective tissue disorders. Patient may have these symptoms along with this symptom of aortic regurgitation. Now, it's very particular about onset of the symptom. This patient with aortic regurgitation usually starts with palpitation. That after palpitation many years, but since 1 year I have been having dyspnea exertion with the PND, and now I have got orthopnea. This may be a very typical history of patient who has got aortic regurgitation. This palpitation is because of the enlargement of the heart, and the heart coming very close to chest wall. So, and because of the volume overload, patient will feel palpitation. And this dyspnea exertion is because of the decrease in the ejection fraction. And patient may have chest pain because of myocardial ischemia as well. In the signs, there are many signs in aortic regurgitation, and all these signs are because of hyperdynamic circulation. And the patient may have Watt-Hammer pulse or wide pulse pressure. So patient may have a blood pressure of around 120, 130 systolic, but diastolic may be 20, 30, or even zero also. So there will be wide pulse pressure, and apex will be heaving, and it will be displaced down and outwards. There will be a systolic thrill in the apex beat, and uh, and and patient may have S3 and S4, third ultrasound and fourth ultrasound. Patient may have a soft first ultrasound. Uh, there will be an end-diastolic murmur at Ebb's point, which will be best heard at the end of the expiration, sitting up and leaning forward position. But there may be other murmurs as well, like systolic ejection murmur in the right upper sternal border and Austin Flint murmur at the apex. This is because of the flow of the blood during systole, causing systolic ejection murmur at the right upper border. And this Austin Flint murmur is the diastolic murmur. This is best heard at the apex, and this is because of the because of the returning blood of the regurgitant flow of the aortic valve hitting the mitral valve. So because of this, there will be a diastolic murmur at the apex, which we call that Austin Flint murmur also. So then basically you have end-diastolic murmur, but you may have systolic ejection murmur at the upper sternal border and Austin Flint murmur at the apex because of the regurgitant flow striking the mitral valve deflect. If you look at this is the ejection systolic murmur you will have, okay, and as the severity increases, the duration of the murmur will decrease. Okay, so this is typical of aortic regurgitation. If you look at the peripheral signs of aortic regurgitation, then it may be a lighthouse sign, Landau freeze, Becker's, Muller's, Dimuche, Kunti, Corrigan's, Traub's, Duroger's, Heels, Rosenbach, and Gerald signs. Of which I would say that Hill sign and Duroger signs these two are very important signs. And if you go through this lighthouse sign, then there will be a blinking of with each beat of the heart, the forehead will become red and blanches away and again becomes red, so as to feel like a lighthouse. But these are very prominent in European people with white skins. Otherwise, you won't see that. In Landau freeze, it's the constriction and dilatation of pupil. In Becker's sign is in the retinal vessels. You'll have a pulsation with each beat of the heart. You'll have a retinal pulsation. And Muller sign is the movement of the uvula. Okay, and with each beat of the heart. And Corrigan is the dancing. It is also called dancing carotid sign. The carotid artery will be very prominent and looks like dancing. Locomotor brachy will be seen in the brachioradialis area, and this is the water hammer pulse. Okay, and Quincke signs are over in the pulsation on the nails, as called Quincke's sign, and Rosenbach is the pulsatile lever, and Gerald's is the pulsatile spleen. And in this DPT is the Duroger's, the pistol short sign, and Traub sign. So, of which Duroger's means if you apply the pressure distally in the femoral artery, and auscultate it, then you'll get the diastolic feel in the femoral artery. And pistol shot is it will have like a sound of pistol shot. You'll find it in the aorta. So these are few things, and I'll come to heel sign, which is very important sign actually, and we'll talk about this one later, which is very important for looking for severity of aortic regurgitation. For the investigations, you can go for ECG, where you'll find LV hypertrophy with left axis deviation, sometimes blocks and conduction defects. In chest X-ray, you'll have cardiomegaly with you may have dilatation of aortic root. Echo is the most important, very commonly done, and the safe, somewhat cheaper test to diagnose aortic regurgitation, and you can do hemodynamic study also from Doppler. Cardiac catheterization is usually done when patient goes for operation or when patient is going for angiography or something like that. So where you can do cardiac catheterization. If you look at the severity of the murmur, then I told you that duration of the murmur is one of the point that we look at. As the severity increases, the duration of the murmur decreases. And in the heel sign, with the help of heel sign, you can find what is the severity of aortic regurgitation as well. Heel sign is the difference between the brachial and lower limb blood pressure. It's generally blood pressure in the lower limb is higher, but it's not beyond 10 to 20 millimeter of mercury. So in heel sign in ER, if the patient has this difference of blood pressure in lower limb and upper limb is more than 20, then we call that a heel sign. If it is between 20 to 40, then we call that a mild, 40 to 60 as a moderate AR, and more than 60 as a severe AR. So this heel sign may be very good bedside, easy way to classify the severity of aortic regurgitation. Management is medical and surgical. In medical, it's like digitalis, diuretics, vasodilators, and if it is because of some treatable cause, then you treat the cause as well. So basically, we give these medicines. In vasodilators, AC inhibitors or ARVs are more commonly used, and digitalis is usually for or you can give beta blockers also. Nowadays, beta blockers are also given for atrial fibrillation, weight control, and for the failure as well. So in the surgical, okay, there is a rule of 55. Okay, if the left ventricular ejection fraction is less than 55 and left ventricular end-systolic volume is more than 55 millimeter, then it's the time that patient should go for operation, and this we call that the rule of 55. Basically, in surgery, the valves are changed. So there's a term called acute aortic regurgitation. It sometimes happens, especially when patient has infective pericarditis or aortic dissection, or maybe during the because of myocardial infarction, patient may develop acute aortic regurgitation, and because the patient develops aortic regurgitation, there won't be any time for adjustment or accommodation. So patient will present with pulmonary condition or edema and hypotension, and this is very life-threatening situation, and you have to be very prompt on management, and they may require prompt surgery as well. In aortic stenosis, till now, if you look at the signs and symptoms mainly, then It's more like palpitation, shortness of breath, exhaustion, and features of right ventricular hypertrophy. That are all what you get in the mitral valve diseases or aortic regurgitation. But aortic stenosis is a little bit different than others. See, because aortic stenosis, only one-fourth is because of the chronic valvular heart disease, and 80% of the adult population with symptomatic valvular aortic stenosis are males. And mainly the valvular valvular obstruction, I would say, valvular obstruction, whether it's at the level of the valve or below the valve or above the valve, that it significantly decreases the orifice of the aortic outlet and thus decreases the aortic left ventricular ejection fraction and thus increases the ventricular afterload. So this is usually because of pressure overload. So there will be obstruction to LV outflow and there will be systolic gradient between left ventricle and aorta. This will then this will then produce some compensations, such as increasing the pressure generated by LV, thus increasing the mass of the left ventricle, causing LV hypertrophy or dilatation. So, patient will have reduction of cardiac output later on, and patient will develop the symptoms. If the aortic orifice is less than 0.5, then we call that one as a critical aortic stenosis. And aortic stenosis will increase the severity of accompanying mitral regurgitation, but aortic regurgitation and mitral stenosis both comes together, then it marks as the clinical finding of each other. If you look at the etiology, it's more like congenital, degenerative, or some kind of obstruction, outflow obstruction, like in hypertrophic cardiomyopathy. And if it is rheumatic, then it's almost always associated with mitral valve. So lone aortic stenosis, if you find that the patient is having lone aortic stenosis, then we generally do not consider it as a rheumatic in origin. It's maybe because of degenerative, because the older patients will present with aortic stenosis, and those are because of degenerative diseases of the valve. So, patient who has got lone aortic stenosis, we generally rule out that it's not because of rheumatic in origin. In the features, clinical features, the clinical features are quite different than that of other valvular heart disease, if you remember. In mitral stenosis or mitral regurgitation or aortic regurgitation, we used to say that it's either palpitation, shortness of breath, or features of right heart failure that are very prominent. But here, it's completely different, and patient here also may be asymptomatic till very late, but patient may present with syncope or dizziness, dyspnea, angina, and patient may have sudden death also. And there may be features of left ventricular failure, infective endocarditis, or arrhythmias may be present. And there is a mnemonic for this, like you call that one as the SAD, SAD. Okay, it starts with syncope, okay, and dizziness. Then patient will have dyspnea and angina, and later on patient will have sudden death. And this the appearance of symptom, okay, is also very much related with its natural history of the disease as well. So if you have syncope, then patient will have lifetime of survival of around only 3 to 5 years. If the patient has a sudden death, angina or then it may be less than 1 year or 1.5 years, something like that. So the appearance of symptom generally correlates with the natural history of the disease as well. On pulse, it will be low volume and narrow pulse pressure. The systemic hypertension is unusual in these patients, and generally, if the systolic blood pressure is more than 160 millimeter of mercury, then we say that the patient doesn't have significant aortic stenosis. So, systolic blood pressure of more than 160 generally rule out that patient doesn't have very prominent or prominent aortic stenosis. Apex beat will be displaced down and out, and there will be systolic thrill. There may be S3, S4, and there will be paradoxical split of S2. So patient may have aortic, pulmonary, or then sometimes then this is normally what it happens, but later on the pulmonary component of second heart sound will come then aortic stenosis, and this will become more prominent, and the aortic valve component of S2 will be less prominent. So as the severity increases, the will be a paradoxical split of the second heart sound, and you will have a systolic murmur. This is also called crescendo crescendo murmur, and it usually generally best out at the upper sternal border, and this radiates to carotid artery as well. So investigations are ECG or chest X-ray, echo, catheterization that can be done, and in the complications, it's left ventricular failure, arrhythmias, complete heart block. Patient may have sudden death. If you look at the natural history, then death is in between 7 to 8 decades. If you have angina or syncope, then it's around 3 to 5 years. Complete heart, congestive heart failure, 1.5 to 2 years, and more than 80% of the people who have aortic stenosis, will have symptoms of less than 4 years also only. So if the patient develops symptoms, then the patient may die within 4 years. So the appearance of symptom is very important in aortic stenosis. I think I'm going to, but I have said this one that there will be a reverse splitting of S2, and less than 0.75 or sometimes 0.5 is called critical aortic stenosis. As well, in the management, it's medical or surgical. In medical, it may be decoction, diuretics, antibiotic prophylaxis for infective endocarditis. There may be anticoagulation if there is atrial fibrillation. Nitroglycerin can be given for angina. And in the surgical, it's a valve replacement or valvuloplasty. Critical AS who are asymptomatic but with LV dysfunction, then they can go for surgical procedure. Okay, these are the primary diseases, mitral and aortic valves, because most of the cases of in clinical practice, you'll find that it's more like because of mitral or aortic valves. Tricuspid and pulmonary valves are a little bit lesser in practice. You'll find lesser in clinical practice, except for tricuspid regurgitation. And tricuspid regurgitation is common not as a primary valvular heart disease, but as a secondary valvular heart disease. So now we'll cover the tricuspid regurgitation. Okay, and then so this is mostly functional and secondary. It's because of later stages of the heart failure. Suppose like if you can remember mitral valve or aortic valve, like aortic regurgitation, leads to a right heart failure. And if the patient has right heart failure, then there will be a dilatation of right heart causing tricuspid regurgitation. So it's mostly because of functional and secondary, and you'll find at the later stages of heart failure. Sometimes it's more like due to rheumatic fever also, but in this is very rare, but this may be common in those patients who use mm, intravenous this substance abusing. So if the patient is taking some kind of IV drugs, substance abusing, then the patient may develop infective endocarditis of the right valve, that is tricuspid valve, and patient may have sometimes because of rheumatic fever as well. So it's morely because of it's a functional, but sometimes it's because of rheumatic fever or infective endocarditis. Okay. But you should remember that if the patient has tricuspid stenosis also, then tricuspid regurgitation, presence of tricuspid regurgitation is not a functional. It usually is because of organic cause itself. Okay, so in the clinical features, this usually results from the systemic venous congestion and reduction of cardiac output. With the onset of tricuspid regurgitation, the pulmonary symptoms of pulmonary congestion decreases and right heart failure appears. Patient may complain of weakness, fatigue, pulsatile neck, cyanosis, jaundice, or edema. Patient may have atrial fibrillation, and patient will have increase in JVP, and apical impulse will be of RV type. That means it will be shifted outwards only, not downwards, and that will be hyperdynamic. There may be S3 in the right ventricular S3. P2 will be loud. There will be pansystolic murmur in the tricuspid region, and patient will have ascites, hepatomegaly, and peripheral edema may be present. So basically, this is the features of right heart failure. So patient having increased JVP, ascites, hepatomegaly will be tender as well, and P2 will be loud, pansystolic murmur. There will be a left sternal heave as well. So these patients will present with features of right heart failure. And if you remember, you'll find similar picture in COPD patient who has got carpopulmonale as well. Because carpopulmonale is the dilatation of the right heart without failure. So patient may have these features in COPD because of the right heart failure. Investigations are same, okay, like you'll have ECG that where you'll have the right atrial and right ventricular enlargement. There may be atrial fibrillation. In chest X-ray, you'll find that patient will have cardiomegaly, and echo. You'll do it for the etiology and condition of the valve with severity. For the treatment, okay, if it is isolated TR without pulmonary hypertension, then you don't have to do anything. Tricuspid regurgitation, since it's secondary to pulmonary hypertension with massive RV enlargement, then if it is because of mitral valve, then you correct mitral valve, okay, and that way you'll be treating this secondary tricuspid regurgitation as well. But most of the time, it's only the treatment of the primary disease which has led to tricuspid regurgitation. But if it is the organic one, then you can go for tricuspid annuloplasty, repair, or replacement as well. But these are very rare incidences. In the stenosis, this is very uncommon and more in females, usually associated with metal stenosis and tricuspid regurgitation. And you will have clinical features like dyspnea, fatigue, There will be a decrease in symptoms of pulmonary congestion, patient with mitral stenosis if um, it is associated with mitral stenosis. Diagnosis is usually missed, and you will have atrial fibrillation increase. There will be hepatomegaly, ascites, jaundice, malnutrition, and mild diastolic murmur in the tricuspid region. Investigations are same, and so treatment is also more or less similar, like just the use of diuretics and for surgical treatment. Pulmonary valve diseases have very less, and it's mostly because of congenital heart disease, and it's in the acquired it's because patients cardiac issues are absolutely stenosis are ASD, VSD, and pharmacology. And I think it's not very like in patient may complain of fatigue, dyspnea, right ventricular hypertrophy, syncope. There will be increase in JBP, parasternal heave. There will be systolic 3, like a pulmonary area. P2 will be delayed. Ejection systolic murmur in the pulmonary artery, and systolic murmur in the tricuspid area may be present because of the right heart failure. So these are very rarely found, and pulmonary regurgitation also. It's very common. It's more common is congenital, or maybe because of syphilis, rheumatic, and maybe arthrogenic, and you will have in the gastric murmur with the gram-still murmur as well, sometimes in the pulmonary regurgitation. So you don't have to know about these gradings, but in ECG you may have very few changes. In just external pulmonary artery segment will be permanent, and there will be cardiomegaly, and echo is the one which will be very helpful to diagnose the lesion. Okay, so I think this is what we have, and if you have any questions, then I'll answer those. Anything? So if not, then we'll stop over here and